Greetings again, everybody. We're going to talk here about diseases of the aorta. So just reminding ourselves about the anatomy of the aorta. This is obviously a dissected aorta. The aorta starts with the aortic valve coming off of the left ventricle. That would be right here. We have a brief ascending portion before we have the arch of the aorta. Now remember that the arch of the aorta sits right behind the sternomanubrial angle. That's the part of your chest where the manubrium, the top part of the sternum, meets the actual body of the sternum. And that is at the vertebral level T4. This level is also known as the plane of Ludwig. So coming off here at the arch of the aorta, we have the innominate artery, which is on the right side, and that gives rise to the common carotid artery, which is going to go up to provide circulation to the right side of the head and the neck, and then also the right subclavian artery, which ultimately becomes a brachial artery and gives rise to the arteries that provide for the upper extremity. On the left side, we don't have an innominate artery. We just have two arteries coming directly off the arch of the aorta, and that's going to be the left common carotid and the left subclavian artery. So the same arteries that we get coming off the right side, we just don't have an innominate artery, a common base for the common carotid and the subclavian. After that point, the aorta turns downward and it becomes the descending aorta, ultimately crossing the diaphragm and giving rise to renal arteries as well as various other arteries, ultimately terminating into the left and right common iliac arteries. So the two diseases we're going to talk about involving the aorta are aortic dissection and abdominal aortic aneurysm. There's some overlap in them, but they are two distinct diseases. They're both surgical diseases, but they can be managed medically prior to surgical operation. So aortic dissection is caused by a tear in the intimal layer, the innermost layer of the aorta. And when I'm saying a tear, I don't mean tearing through, I mean tearing into. So what happens is that blood is burrowing underneath the intima. So it's getting between the intima and then the next deepest layer. So the intima is your innermost layer in your aorta, and then there's another layer below that. And so blood is going not only above the intima, but below the intima. And so because the other two layers on the outside, not the intima, but the other two layers are not strong enough to hold blood pressure, the patient is at risk for aneurysm and rupture. So aortic dissection is a problem. This can also cause hemopericardium. Aortic dissection itself is a medical emergency in as much as it needs to be treated when it's found. A lot of times this does characterize as an acute pain. So fortunately for treatment, when the aortic dissection starts, the patient will know it. So it's usually characterized as a sudden tearing or ripping pain that radiates to the back. So when you have the patient that comes in with chest pain and they describe it as crushing, then you're going to think of possibly an MI. But if they describe it as tearing, or it radiates to the back, or it's a ripping pain and it came on very acutely, not insidiously, then you're going to think possibly aortic dissection. Looking back at the patient's history, the number one risk factor is hypertension. But there are other things that we can associate with aortic dissection. One of them is connective tissue disorders. So if the patient has Marfan syndrome or Ehlers-Danlos syndrome, acute trauma can be a cause of aortic dissection, and there is a peripartum aortic dissection, but that's very rare. But do remember that pregnancy can be associated too with aortic dissection. So this is the DeBakey and Stanford classifications of aortic dissection, and this is more important for surgery, but I did want to put it up here just to show that there are different places where the aorta can become dissected. And I also wanted to note that the type 1 DeBakey classification is the most common. So to have your dissection at the ascending aorta. But it can happen at any point in the aorta. So when we look at a patient with aortic dissection, if that's on our radar, this patient will have a history of hypertension. They may also or on the other hand, have a history of connective tissue disorders, trauma, or pregnancy, but most commonly this is going to be an older patient with hypertension. The symptoms are going to be a severe tearing, stabbing, sharp pain that radiates to the back, but it doesn't have to. It can be just in the anterior chest. What's most important is that this pain is going to be of acute onset. So this isn't going to be something that the patient has had for 4 hours. This is going to be the patient was mowing the lawn, all of a sudden they got this tearing pain and they went to the hospital. This is severe pain. It comes on all of a sudden. So most of the time when you interview these patients, they can tell you they've only had this pain for 20 minutes. Okay, so dysphagia can be present, and the reason that dysphagia can be present is in case we have an aneurysm in the abdominal aorta or in the thoracic aorta. The aorta is very close to the esophagus, so you can have difficulty swallowing, difficulty eating if you have aneurysm with your aortic dissection. So dysphagia is something that possibly could be there, but it doesn't have to. Pain is classically posterior. That's the classic presentation of aortic dissection, just simply by where it most commonly presents, but it can be anterior, abdominal, or flank pain in unusual cases. So just because it's not back pain, it's not radiating to the back, doesn't rule out aortic dissection itself. But back pain does make you think aortic dissection. The blood pressure in aortic dissection is usually variable, but it can be hypertensive. These patients can present with hypertensive emergencies, so blood pressures over 160/90, for instance. You may hear muffled heart sounds, and if so, that would be a sign of a hemoperitoneum, which is not unlikely in patients with aortic dissection, but again, you don't have to hear the muffled heart sounds, you don't have to have hemoperitoneum. What you will have, though, is a new diastolic murmur, and that's because the aorta has become weak. Because it is dissected, it's become weak, and it's no longer able to pump the blood out the ascending aorta, and so blood is regurgitating back down retrograde through the aortic valve, and so you're getting a diastolic murmur, similar to what you would have in aortic incompetence. Unequal radial pulses are not unusual either, and that's also due to the fact that where do you get your radial pulses? Well, it's going to come from your innominate artery, and it's going to come from your left subclavian artery. So if you have a dissection in between them or before it, you can possibly show up with unequal radial pulses. Adventitious lung sounds are rare in aortic dissection just because that would show a late progression of the disease. So for diagnosis, if the patient doesn't have that typical back pain, or the pain, if they can't describe the pain as acute, then you're going to probably want to get an EKG. But if they have the classic signs of aortic dissection, tearing, stabbing, sharp back pain, and it came on all of a sudden, then you can go ahead and jump right to CT. You're going to want to get CT with contrast for these patients because it's going to help you be able to see it's going to help you see if there's a dissection or not. It's a lot more difficult to see the dissection if you don't have contrast, and I'll show you some examples. And with the CT, we can look for location of our dissection and severity, and we can also look for hemopericardium. So this is a good view of an aortic dissection here. So here you have your vertebral body, and here you have your aorta. So they're pretty close to each other. And if you look really closely, there's this line right here. And this line is the intima, and underneath is the blood that's burrowed underneath it. And what we're worried about is this tissue right here, because this tissue does not have the strength of the intima, and so this tissue can rupture, and then we would have another problem on our hands, which would be a ruptured abdominal aorta. And that would be something like this, where we have, here is our tissue here, this is our intima flap underneath which the blood has drawn, and now we have a rupture. And so blood is coming into the peritoneal space. So big problem. And this is about at just below the level of the diaphragm. Here you have your liver here. Spleen here. Okay, so here's another one. This one looks like it's about to rupture. So here's your aorta, here's your intimal flap, and here's your blood underneath the flap, And look, we don't have much space here. We don't have much wall. So we're about to have a rupture here. So you can see how this is a big deal. Aortic dissection is not something to play around with. So any patient comes in with aortic dissection, first thing is to manage their ABCs. Generally, these patients are not in any kind of acute problem hemodynamically. So once we have narrowed it down to aortic dissection and ruled out MI, we're going to send these patients off for CT. We're going to also start IV beta blockers, because what is going to worsen the aortic dissection? Well, the things that cause the aortic dissection. High blood pressure. So we give IV beta blockers. Esmolol tends to be what we use. We can also give nitroprusside. So IV beta blockers and nitroprusside are our best next step in the therapy of this patient, and in the best next step for the diagnosis of this condition, we're going to do helical CT. We can also manage the pain with IV opiates, fentanyl. It doesn't really matter, fentanyl or morphine, whatever you've got. And then these patients are ultimately going to need surgical correction. So abdominal aortic aneurysm is kind of on the same spectrum, but it doesn't, with abdominal aortic aneurysm, you don't necessarily have to have a tear into the intima. You can just have an overall weakening of the wall that can dilate out. So what an aneurysm is, anywhere, you can get aneurysms anywhere, not just in the aorta, it's an outpouching of the wall due to a weakness. And the aorta is very, very, very susceptible to getting aneurysms because the aorta holds a very high blood pressure, 120 over 80, 160 over 90, and so forth. So the aorta has to be very strong, and when the aorta is weakened, then it can dilate out due to those pressures. So normally our aorta is 1.9 centimeters, but that's just the average. It can be, I'm sure there's a standard deviation. But it's always abnormal when it's more than 4 centimeters. And so for the USMLE, there's a lot of disagreement between surgeons and internists as to when we operate, when we do medical treatment. With the medical treatment, you don't have to open the patient up, so you avoid all those surgical risk factors. But with surgical therapy, you've got post-surgical morbidity and mortality, but then you also do have a definitive cure. So we want to know when we operate and when we don't. And since doctors don't really know when we need to operate and when we don't, what we go with for the USMLE is when we always know we never operate and when we always know we do operate. And so you never operate when the aneurysm is less than 4 centimeters. Never, never, never operate. Always, always, always operate when the aneurysm is greater than 7 centimeters. Centimeters. I don't know. I might have said millimeters earlier. Centimeters. So less than 4 centimeters, don't operate. Greater than 7 centimeters, operate. And that's just simply because when the aneurysm is less than 4 centimeters, your yearly mortality rate is less than 1%. When it's greater than 7 centimeters, your yearly mortality rate is 1 in 5. So that's kind of where we draw the lines, at least for the USMLE. Of course, the primary complication is rupture and hemoperitoneum and shock and sudden death. So the risk factors for abdominal aortic aneurysm are going to be the exact same as the risk factors for dissecting aorta. And those are going to include hypertension, smoking, COPD, male sex, age, Caucasian race, and connective tissue disorders. Usually, an abdominal aortic aneurysm itself is asymptomatic, but sometimes you can get early satiety, you can get dysphagia, just because if the aneurysm presses up against the esophagus. You might also have a patient coming in and complaining about this mass in their belly. Sometimes they'll say, oh, it's a hernia because it looks like a midline abdominal hernia. But then when you feel it, you notice that it's pulsatile, and that's definitely not a midline abdominal hernia. If the abdominal aortic aneurysm does become ruptured, syncope, shock, and sudden death are the sequelae of a ruptured aneurysm. And only about 20% of these patients where their abdominal aortic aneurysm ruptures will actually survive. So you don't want it to get to that point. So this is a normal abdominal aorta as seen by sonography. So you place the sonogram right over the patient's belly, and you see the vertebral body here, their back, and here you have their aorta, this nice circle that sits right on top of the vertebral body. And right to the right of it, you'll have the inferior vena cava, and you'll know that this is the inferior vena cava and not the aorta because the wall is irregular. The esophagus is just going to be a little small tube, and it sits right anterior to the aorta. Okay, I'll contrast this with an abdominal aortic aneurysm. Here's another. This is just to back that last one up. Okay, here's your abdominal aortic aneurysm. So this is kind of zoomed in a little bit, but look at this aorta. First of all, this aorta is a little bit bigger. Secondly, this aorta has a saccular component. This is the aneurysm right here. So this is not supposed to happen. How are we going to measure this? We're going to measure this from the distal point of the saccular component to the distal point of the aorta. That's going to be our measurement. And indeed, that's what this blue circle is. And as we measure that, I don't see an actual measurement on this picture, but this looks to be about, I would put this at about 4.5 or 5 centimeters. So in that gray range, but I'd probably lean towards medical therapy with frequent monitoring. This patient is definitely going to need surgery. This is their aorta right here, and you can consider this part of aorta normal. So their aorta should only be about this big, and the saccular portion is this big. This is ginormous. So this patient will definitely need surgery. You can also get a longitudinal view of the aorta. This can be helpful. You just switch the direction of your sonogram, and you can see get a different perspective of the aorta. So here we have, we're looking down. This is superior. This is inferior down here. Here's your liver. Here's your aorta. And here you have your superior mesenteric artery going down to supply your mesentery, and then here's your celiac trunk coming off right here. So this is normal. We don't have any aneurysm of the aorta here. No saccular components. This is abnormal, and again, I zoomed in here because you couldn't really see it on the regular sonogram. You have to look really carefully. It's not always going to be as clear as you might want it to be. A lot of times, because you can get thrombi in the very large thrombuses in the aorta, in the saccular component. So there is actually a very, very big thrombus here. This is your aorta, and then this is a thrombus. So I would probably put this at about 4 or 5 centimeters, but this is definitely an aneurysm. And you just have to look at the coloration. You can see that if it were like this, then it would be normal, but you've got this blacker color here, so this is a thrombi. Kind of difficult to tell just because it's a thrombi and it's not just a clear sac, but this is also an aortic aneurysm. Ignore that where it says normal aorta. Okay, so how about treatment? So let's say that this patient does not have a ruptured aneurysm and it's less than 4 centimeters. Then if the patient, first of all, if the patient is asymptomatic or has just simply a pulsatile abdominal mass and they're less than 4 centimeters, we're going to manage them on an outpatient basis, but we're going to want to monitor them every 6 months. So first, we want to reduce their risk factors. They can't control their race, they can't control their age, they can't control their sex, and they can't control their genes. So hypertension and smoking are going to be the things we want to manage. We're going to want to get them off smoking, and we're going to want to lower their blood pressure. So as far as risk reduction, we will stop their smoking. If we need to prescribe them something like Zyban, which is bupropion, or varenicline, which is Chantix, then we can do that. Usually the USMLE will just give you stop smoking. Step 3 may give you an option of bupropion or varenicline as an option. That would certainly be a good idea as far as stopping smoking. Beta blockers are essential in these patients. It lowers the blood pressure, and that's what's necessary to keep this aneurysm from rupturing. So metoprolol is a good option, but any beta blocker would be a fine choice. And then we're going to want to recheck these patients every 6 months. 6 months is at least the amount you want to check them. If their aortic aneurysm is larger, you may check them more frequently, but for the USMLE, the standard is every 6 months. If the patient has a ruptured aortic aneurysm, you're going to know it. These patients aren't going to be the ones who walk in and say, hey, I've got a pulsatile abdominal mass. They're going to be the ones that come in on stretcher, they collapsed, they were with their loved ones, and now they're in the hospital and they have a blood pressure of 60/30. So the first thing you're going to do in any patient that has hypotension and hemodynamic instability is to insert bilateral large bore IV lines with fluids as rapidly as you can. And then at that point, when you have sudden loss of consciousness, you're going to want to have an EKG. And in this case, usually the USMLE is going to tell you patient has a history of abdominal aortic aneurysm. If they don't, then you get an EKG because MI is the number one cause of this kind of sudden cardiac death. But if they tell you history of abdominal aortic aneurysm, get an abdominal ultrasonography stat, and then you're going to want to have surgery on call at the same time, and you're going to be sending these patients off for emergent reparative surgery. Unfortunately, only about 20% of these patients go on to survive. And that is it.